Bile duct injury, BDI. Bile duct injury is a significant complication that can occur during surgical procedures, most commonly during laparoscopic cholecystectomy. It is a serious condition that can result in morbidity, biliary strictures, or even death if not managed promptly. Types of bile duct injuries. BDIs are classified based on the extent, mechanism, and location of injury. The Strasberg classification is the most commonly used system. Strasberg classification of bile duct injury. 1. Type A, leakage from minor ducts, such as the cystic duct stump or Luschka ducts. 2. Type B, occlusion of an aberrant right hepatic duct without leakage. 3. Type C, transection of an aberrant right hepatic duct with leakage. 4. Type D, partial laceration of the common bile duct, CBD, without transection. 5. Type E, major injuries. E1, injury 2 centimeters below the hepatic duct bifurcation. Injury 2 centimeters below the hepatic duct bifurcation. E3, injury at the bifurcation, preserving the confluence. Separation of the ducts at the bifurcation with no communication. E5, combination of E3 or E4 with aberrant right duct involvement. Causes and risk factors. 1. Surgical errors, misidentification of the biliary anatomy during procedures like cholecystectomy. 2. Inflammatory changes, chronic cholecystitis leading to distorted anatomy. 3. Aberrant anatomy, variations in bile duct anatomy increase the risk of injury. 4. Laparoscopic challenges, limited field of view and tactile sensation during laparoscopic surgery. Clinical presentation, immediate symptoms, bile leakage, abdominal pain, fever, and jaundice postoperatively. Delayed symptoms, strictures, cholangitis, or biliary cirrhosis weeks to months after injury. Investigations. Initial workup. 1. Blood tests. Liver function tests, elevated bilirubin, alkaline phosphatase, AST. Leukocytosis indicating infection or inflammation. 2. Imaging studies. Ultrasound detects biliary dilatation or fluid collections, biloma. CT scan identifies bile leaks, collections, and other intra-abdominal complications. Definitive investigations. 1. Magnetic resonance cholangiopancreatography, MRCP. Non-invasive, provides detailed visualization of the biliary tree. 2. Endoscopic retrograde cholangiopancreatography, ERCP, diagnostic and therapeutic, identifies the location of injury and allows for stenting or sphincterotomy. 3. Percutaneous transhepatic cholangiography, PTC, useful when ERCP fails, especially in high bile duct injuries. 4. Intraoperative cholangiography, IOC, identifies injuries during surgery. Treatment of bile duct injury, acute phase management. 1. Initial stabilization, treat peritonitis, sepsis, or shock with fluids, antibiotics, and drainage of collections. 2. Bile leak management, place percutaneous or endoscopic drains, ERCP-guided stenting. Definitive surgical repair. 1. Minor injuries, type A and type D, endoscopic stenting and sphincterotomy. Small lacerations can be closed primarily if identified intraoperatively. 2. Major injuries, hepaticojejunostomy, Roux-en-Y, gold standard for significant injuries, E2, E5. Primary anastomosis with T-tube for partial injuries, especially in low-risk patients. 3. Delayed repair. Perform in a controlled setting after inflammation subsides, 6 to 8 weeks. Complications of repair. Strictures requiring balloon dilatation or repeated surgeries. Recurrent cholangitis or bile leaks. Prognosis and prevention. Outcomes depend on the timing of diagnosis and expertise in repair. Preventive measures include thorough understanding of biliary anatomy, use of IOC or laparoscopic ultrasound, referral to specialized centers for complex injuries. Timely diagnosis and a multidisciplinary approach are critical in managing bile duct injuries effectively.